interest of time, we'll move swiftly on to our next speaker, who is a consultant radiologist, Adam, who's going to be talking about improving the speed and quality of diagnostics. So over to Adam.
So that's a tall order in 10 to 15 minutes, but I'll try my best. So I'm Dr. Adam Aboalkaz. I'm a consultant radiologist working at the University Hospital of Wales. I've got a subspecialty interest in abdominal and pelvic imaging, so that leads to colorectal, urological imaging, and hepatobiliary malignancies. And then I do a lot of benign work, so that's pelvic pain, endometriosis, pelvic floor, and general abdominal pelvic conditions. I'm going to try and cover a few different bits in this, but I realise that the audience is quite general. So I'm going to have some key topics that I want to put that will align with the key shifts, but please feel free to ask any questions around that topic in the Q&A. So first I'm just going to outline the diagnostic landscape. So as I was saying, I subspecialize in abdominal pelvic imaging, but when you look at radiology in a general in a general scheme, we body part it, and that's what we were talking about earlier, is in moving from body parts to a whole body approach. Typically, the radiology department will have head and neck neuroradiologists, chest radiologists, body radiologists, and then musculoskeletal radiologists. And for anyone that's not had an ultrasound scan or a CT scan or an MRI scan, we then use different modalities depending on which part of the body we're looking at. And so when we have this broad term of diagnostics, it's often forgotten that there's a specific test for a specific condition. And sometimes we talk about diagnostic delay a lot of the time, and that's because somebody's been sent for a test, it's not quite the right test, or it doesn't have the right type of contrast or the right type of sequences. And patients, especially non-medical patients, get quite frustrated because they think they've had a test, the GP or their primary physician or surgeon has sent them for this test, why are they not getting the answers from this test? Part of that reason is because it's a little bit more complex than one ultrasound or one CT fits all. And so where I work is in this section, essentially, that body aspect in the middle, and I use all of these modalities in my work for different organs. So if I'm looking at a liver or I'm looking at a kidney, I'll use a different type of modality. And it's important to be aware of that. So ultrasound is where I'm the clinical lead of. So in my practice, I do a lot of ultrasound, and that's interventional and diagnostic, but I also report a lot of CTs and MRIs. And when I was going through medical school, my only interaction with the radiologist at that point was kind of being shouted at. And if there's a lot of doctors in the room, they'll probably feel this as well. You get shouted at, you're told that's the wrong test, go out, go and get more information, go see the patient again, so on. We're slowly moving away from that, I hope. But realistically, it's because we're getting lots of referrals in that maybe aren't appropriately placed. They might have had given the wrong clinical information, and that with this lack of digitalization, it's quite difficult to then write an email to that referrer and get more information and so on. But that's something we're trying to work on, and people skills is something that, as a radiology department, we're trying to work on. So most specialties use a combination of this, and I'm just going to focus on the abdominal pelvic aspect and predominantly the ultrasound, but again, feel free to ask questions about any of these topics. So when we're looking at abdominal and pelvic ultrasound, I don't know how well that picture shows on the side, but that's your normal ultrasound. So if anyone has had an ultrasound scan or seen one, typically maternal scans are what people associate with ultrasound. They see the baby's heartbeat going. That's just a liver scan. So this is what we call B-mode imaging. And this would be the general state of play for most people that have an ultrasound in the NHS or in the private sector. They'll be going to a sonographer, a consultant, some sort, and they'll be performing this kind of scan. So depending on where you have your scan, there are different types of tests they can do at that point. So you can look at the flow within that organ, you can look at the different fat content within that, and you can look at the different aspects of fibrosis. And then what we're trying to get more and more education into is these advanced techniques, which are where you can use contrast ultrasound. So this is a patient having that same test, so that liver on the right is having that same test, but you've injected a dye while you're scanning that patient, and it shows you a more dynamic approach as to what's going on inside that body, as opposed to the static pictures. And then we've got, for example, for patients with endometriosis, we've got dynamic tests, so understanding how the body isn't just a static focus. You can move different parts of your ultrasound machine, you can ask the patient to do different things to get different images. And I think what my projection of radiology is that we're going to hopefully move from that picture on the left where it's just a static picture that gives you a limited amount of information and use as much innovation as possible to get to these pictures at the bottom where we can really get the most out of our tests. So a patient is sent for a test, they get a lot of information at that point, maybe not all to the patient, maybe to the doctor that's looking after them or to the team that's looking after them, but at least that visit has utilized the maximum amount of that appointment. Whereas at the moment what we see is the patient comes in, it's the wrong test, they have the ultrasound or they have the CT, they then go on and have another ultrasound or another CT, and so on and so on and so on. And that's where the inefficiency, that's the biggest inefficiency that I see. It's that we're getting to see these patients, and if it's on an urgent suspected cancer basis, we'll see them quite quickly, but it's the wrong test, and then they have to wait another few weeks to get another test, and so on. So that's what I really want to try and work with anyone to try and stratify. So we're going to move to some problems. So in the NHS, we love to talk about problems, and there are a lot of problems. So the big problems that I can see, demand. So imaging has skyrocketed. Over the last decade that I've been working in imaging, we can see that scans have gone up massively. So back in 2005, we were getting about 100, this is purely ultrasound, we were getting about 150,000 requests. That's now trebled plus. That number keeps going up. And it's because patients are getting more complex. We have an aging population, we've got more medications, we've got more treatments. Imaging requests are going up and up and up. So the demand is increasing. The workforce, on the other hand, is decreasing. We've got lots of retirement, lack of training posts that are filling those spaces. We've got people that are moving to different roles and working in more managerial roles or working in industry or different areas that aren't on the clinical ground. So we've got a rising demand, we've got a reduced workforce. AI will hopefully help bridge some of those gaps, and I'm actually optimistic about that. You won't find many radiologists saying that, but I am quite optimistic about that. But it's not going to be, I don't think, the be-all, end-all of it. As for service, because we have a high demand and we have a reduced workforce, you don't have to be a genius to figure out that we're going to have a delayed service. There's going to be high waiting lists, which we've talked about. And as a part of that, patients' then perception of the NHS is going down. They're waiting a long time for these scans. The scans aren't appropriate or aren't giving them the right answers. They're not happy. So, and Aaron Bevan famously said that as long as there are people to fight for the NHS, it will still be there. And so I'm really inspired to see all of you here today because I think that's what we're trying to do. So just to summarize that, in a funnel point, obviously, we've got an increased demand to a reduced workforce, limited service, poor perception. The patient then is not happy with the service, and it goes round and round and round, and that's where we are. So how can we try and improve that? So I'd like to think I'm optimistic, so we're going to look at some solutions. So one solution that I'd like to talk about has to fit my rules. I don't do many managerial terms, but I like to say things should be good. I think you all know where this is going, fast and cheap. And there are a few ways that we can do that. So increasing the workforce, that is not going to be cheap. As radiologists, we're not cheap. And in general, healthcare workers are not cheap in general. So it's hard to get that. But that's something we should be working on in the long term. Improving the quality of requests. So we've got lots of new requesters, people that hadn't request tests before. And as I said, my own experience in medical school of dealing with radiologists, and even in my pre-radiology career, wasn't the best to set me up to request these tests. So we need to try and educate referrers on what the most appropriate test is and how we can get that done. Increasing diagnostic accuracy. So that's what I'm going to focus on. How do we get the most out of the test that we're already doing? And then increasing availability to diagnostics. So we've got all of these community hubs dotted about the country. We've got increased pathways that get people in to see radiologists and different clinicians within a couple of weeks. So I think that's working around in the background, and that's the one that I want to focus on. And essentially getting from symptoms to management as quick as possible. The funnel seems to be diagnostics for a lot of things. And so just to show you this picture, so I'm going to talk about this essentially today, but this is different modalities, and they all show the same patient, and it's just how we use each modality for the right condition. So the current pathway in a lot of places, if you get a patient with vague abdominal pain, abnormal blood tests, liver function tests, they might present to their GP. So the GP has a quandrum. Do I send them for an ultrasound or do I send them for a CT? And if the patient is really, really unwell, the GP is going to feel they've got more of a justification to go for a CT. If the patient looks quite well, they might go for an ultrasound. And this is a real-life case that happened some years ago. So this patient was sent for an ultrasound. And the ultrasound looked a little bit heterogeneous. So it's indeterminate. And the term that radiologists love, equivocal. So it's an equivocal ultrasound. It's not definitely bad. It's not definitely right. So they had two options here. Do we send the patient for a CT scan? Do we discharge the patient? So the person that did this sent the patient for a CT scan. And this CT, I know you don't do imaging as regularly as I do, but hopefully you can see these black spots all around the CT. Those aren't meant to be there, okay? All of these things are metastases within the liver, so this is not a good sign. But that ultrasound, and I know the lights are bright, but I can promise you I've looked at that for a long time, that ultrasound does not show the same picture. That ultrasound looks very heterogeneous. It does, this was done over a very short period of time, so it's definitely the right thing. But it's a different modality. It doesn't get you the answer. That patient then was sent for an MRI scan, and again, you can see the white dots on the MRI scan correlate to the black dots, so easier to pick up. And if you're a radiologist reporting, it makes a lot of sense to do that, and then that gives you a diagnosis. So this is the pathway that could have happened for this patient. It didn't quite happen like this because I scanned the patient over there, and what we did that changed this, so this would be the normal pathway if this patient had presented. He would have waited 2 weeks for his ultrasound. He would have waited another couple of weeks for his MRI or his CT. Then he would have waited a couple of weeks for that to be reported. So we've got a backlog of reporting because you need a physical human at the moment to report that. And then that would get to a diagnosis. That would go to the GP. The GP would then go through that diagnosis at some point, call the patient back, and so on. You can imagine that takes a long time. But at minimum, let's say that was perfect. That took 8 weeks. And worst case scenario, I saw that ultrasound, didn't see anything wrong with it, and I discharged that patient, and then they're out the system until they represent at some point with something quite horrendous. Fortunately, what we did do is we had access to a contrast media with our ultrasound. And you can already see, I don't know how well that looks to where you're sitting, but can you see those black dots in the big pink bubble? So that correlates to the CT and to the MRI scan. And that only takes 10 minutes to do. So that patient has waited 2 weeks for their ultrasound. They've come in. There's something vague about that ultrasound that we're not quite happy with. Maybe not confident enough to send them straight to CT or to MRI, but we've got another use in our artillery, and we can basically use that as a screening tool for patients who have maybe abnormal liver ultrasound. If this was vice versa and the patient had a benign finding on their ultrasound, so something like that, and I appreciate this isn't a diagnostics lesson, but if they had a benign thing on their ultrasound, we could discharge them safely. And again, it's only taken 2 weeks. So this is the best case scenario. It's taken us 2 weeks rather than 8+ weeks. And it's very, very simple because you think, oh, well, actually, this takes lots of training, this takes new equipment, this takes lots of money. Almost every ultrasound machine in the country that's been bought within the last 5 years has the capabilities of doing this. And everyone that's doing these scans could be very easily trained to do that next step. But it's the innovation to want to do that and to fund that. And I appreciate I'm going over time, so I won't go too long. But it's also NICE approved, and it's been costed that it saves money in the long run as well. So I'm not here to talk about the cost, but it does also save money in the long run. So for me, the gold standard service would be to have a test that basically gets us from the first diagnosis to the end diagnosis as quick as possible. Education is going to be key. So training people, training sonographers, training radiologists, training people to do this, that's going to be quite a key point. Materials, as I said, it's already readily available. All you need to buy is that media, and then that will allow you to then perform those tests quite quickly. The cost, I'm not going to dwell on that, but it's already been cost set by NICE, and they've approved it in most settings to be cheaper than if you have a contrast service. And time. That's the key thing. If we can catch these patients earlier, if we can find one of those black dots as opposed to all of those black dots, then we can have a much quicker route to treatment and we can do a better outcome for our patients. And then just because, so there's an Aaron Bevins quote again. So just an overview. So ultrasound is a key modality used in clinical diagnostics. The key problems we have are increased demand, reduced workforce, and I wouldn't say, I've put the word suboptimal tests because most of the tests are fine, and most patients are attending with few symptoms that are probably going to be normal, but in some instances, some of these tests are suboptimal. Identifying solutions, so improving the requests, increasing the workforce, and improving the accuracy of our tests. I think that's the key message here. And the gold standard for me is just a high-quality service with a reduced delay. Just before I go on to the discussion, so it's already trying to brush me off. So chronic pelvic pain is something else that I work in, and it's another inequality that we see between the genders. So if you have testicular pain or testicular scrotal swelling, I'll probably see you within a couple of weeks for an ultrasound. If you've got chronic pelvic pain as a young female, it's probably taking a minimum of 7 years to be seen by someone for the right diagnostic test. And this is another pet peeve of mine. A lot of those patients that have those ultrasounds, they're suboptimal as well. So those ultrasound tests are falsely reassuring. Do a lot of pelvic floor work as well, and a lot of obstetric injuries to patients who have fecal incontinence and things like that. And it's the same problem. These patients have significant delays before they get to diagnostics. And I think the key here is just education and awareness. So that's why I'm using this platform to raise awareness to this, because it's not something that's talked about a lot. Patients having intractable pain, having incontinence, it's not nice conversations that people want to talk about. But unfortunately, it's real life, and I see it a lot. So the main aim here is if you see patients suffering from that, I don't know how many of you are clinical or non-clinical, but if you do, please refer them to the right specialties, because that will significantly delay their diagnostics. And if in doubt, we, as radiologists, I think we're approachable. Just email us, and we'll probably be able to signpost you into the right way. Okay, and then I'll leave for discussion and questions at the end, okay? Thank you.